So in general, the heart failure is still one of the major challenges in the cardiovascular disease, and it's counting 1 to 2% in the developed countries of the heart disease, but it's still high in prevalence in our countries, including Mongolia, being up to 5% in terms of the prevalence. And then when we look at the heart failure patients, nearly 30% of them has a left bundle branch block and reduced ejection fraction, which is considered good candidates for our CRT treatment. But we can still see there is a lot of patients who are still not receiving the medication treatment, even if they are indicated. So what is CRT? We all know that quite significant number of the heart failure patients, they are developing dyssynchrony in their left ventricular function, and then we try to use this device to create synchronous contraction. So why we are discussing about left bundle branch block so much is that actually this is more widely occurring among heart failure patients. And then when you look at the mortality, actually patients who has left bundle branch block compared to right bundle branch block or no block, they have higher mortality rates. So we are interested in treating or making left bundle branch block to disappear. And CRT is already well-known, well-evidenced treatment who is making a lot of beneficial effects electrically and mechanically. And then there are certain patients who are response to our CRT treatment and some does not respond, but those who are responding to the CRT treatment, they have a lot of clinical improvements in terms of hospitalization, that is dramatically decreases, and also in terms of all-cause mortality. Actually, those patients who are responding to CRT, they have a much better benefit from in terms of all-cause mortality. And this is also true for the mortality that is related to our cardiac problems. But not quite earlier studies also showing that quite significant number of patients still not responding to the CRT treatment, but there are also significant number who is responding or even super responding to this treatment. And then actually later studies from the region, it is showing that actually the response rate is quite increasing, and it can reach up to more than 70 or 80% now. And especially for those patients who are at the earlier stages of the disease, they are responding better to this treatment. But those who are in a late stage, actually they have much less response to the rate. And this kind of response rates are increasing because now actually our patient selection is much better. We know who is actually responding better to this treatment. And also our procedural success rate is much better thanks to all the different technologies, different tools that are available now. Because we can see earlier studies, they have still quite a number of patients which we could not successfully implant the cardiac resynchronization therapy device. But later studies, actually, it's reaching much higher success rate for our procedures. And then we can also discuss about optimization, because the companies are providing different opportunities or different materials so that we can do many different optimization for the CRT so that the patient can better respond. For example, one of the great tool was the multi-point pacing, where we can select different points to pace the heart from different segments so that the patient can benefit better. And it was also shown by the studies, the response rate after multi-point pacing is dramatically increased. And there are different algorithms from the companies, different companies producing like SyncAV, adaptive CRT, that can help us actually to optimize AV or VV synchronies within. And these kind of things, algorithms and tools, are increasing our response rate from the patients. And based on all these achievements, actually the guidelines are still highly recommending cardiac resynchronization therapy to be one of the first-line treatments for especially heart failure patients who have left bundle branch block and with a wider QRS duration and reduced ejection fraction. But this, although the class is lower, but it's still recommended for left bundle branch block patients, even if their QRS is not too wide. But when it comes to non-LBB patients, because they are, the recommendation level is decreasing. And the recent guideline, actually, they start to also discuss about other possibilities, including his conduction system pacing, and it's already starting to be in our guidelines. But considering we still need some more, studies, evidences, they are not at the highest class of recommendation, but they are still coming into our guidelines. But I believe the colleague following will discuss or touch on the conduction system, so I will skip a little bit. But then there is a discussion about CRT and left bundle branch area pacing. How about if we combine them together, whether we can achieve even better results? Because CRT biventricular pacing has good results, good response rates, and left bundle branch area pacing also does. And if we combine them, whether we can find better results or not. So this kind of implantation could reach up to 80% from the colleagues, 80% successful implantation rate. And they have chosen heart failure patients with left bundle branch and in heart failure problem. When we look at the procedural characteristics, they are actually more or less comparable, and they did. And then after that, we found actually even greater narrowing of QRS could be achieved if we combine these two methods. So for example, from the graph, we can see the patient average QRS is over 180. After biventricular pacing, it lowers down, and after LBB pacing, it even lowers down. But when we combine it, it is even lower. And we can also see from the clinical improvements, actually there is a much more improvement within in the clinical scenario. And this was quite stable after follow-up examinations. And then I was looking also the regional data. Actually, there is a team from China also doing this kind of study. And left bundle branch optimized CRT and biventricular pacing. The age group was more or less similar. And then they found also similar findings. When you look at the QRS duration, actually after left bundle branch optimized pacing CRT, the QRS is even lower than biventricular pacing alone. And then when you look at the clinical results, actually the heart failure signs and symptoms are decreasing even more in the optimized CRT group, and also this is true for their survival rate. So just in conclusion, although CRT is still well-established treatment option, and we have much increased procedural success rate, improved response rate, and then we are now facing even more interesting opportunities that could be studied further.